Well, those of you who don't know me, my name's Hassan Usmani. When I was writing this up, my fiance was like, what the hell does this even mean? And, I thought it was interesting, but there's a lot that happens with a simple thing as an ankle sprain. A lot of us, just kind of write it off, but what ends up happening is that it can catapult itself to becoming something chronic to where it actually starts affecting people. So we'll go through this. If you guys have any questions, just, raise your hand or give me a holler. So I think it all kind of starts with the definition of a sprain. There are two methodologies. One is you define a sprain by stretching of the ligament, and then it goes into a bunch of the different nuances. I don't particularly like it because I just like to know if something is torn or not. So I actually, just treat a sprain as an actual torn ligament. I trained in New York City, so I pretty much heard everything on Thursday, Friday, Saturday nights at 2 a.m. when I got called that, this and this happened. So this is a common phrases of how a lateral ankle sprain can kind of present subjectively, of like what, a person will tell you what happened. Most common is I rolled my ankle, it hurt, it got better. I twisted my ankle gave out. I missed the step, that happens pretty often. I slipped on ice, I think that's pretty common, everyone's aware of that around here. And then this is, I think, the most interesting one, that I'm so clumsy and I continue to fall again. And people will get these elaborate workups for, vertigo and all this other stuff, when in fact they just have chronic lateral ankle instability. And then something that I will never forget is, my heels and tequila don't mix well, which is, I'm sure, probably doesn't. There's about 2 million acute ankle sprains that happen a year in the United States alone. What's even more interesting is that of all the lateral ankle injuries that even occur, 85% of them are sprains. So they're not fractures, they're not, tendon tears, they're not even, fifth metatarsal fractures. They're all actually somewhat falling under this umbrella of an actual ankle sprain. And then the beauty of it is that because ankle sprains get better so quickly, 7 to 10 days, you're feeling better. 55% of even the worst ankle sprain will just go on and continue with life. So they never even actually, seek a doctor. They don't go to the urgent care. They don't go to the emergency room. They just continue living. The anatomy, nobody really cares about this, but I figured I'd at least discuss it. There are 3 ligaments on the outside of the ankle that kind of constitute a lateral ankle sprain. The first one so when you have lateral ankle sprains, they occur systematically and predictably. When you roll your ankle, the first one to go is the anterior talofibular. It actually goes directly straight forward. And then the second one to go is the calcaneofibular. It goes from the fibula directly down. And then the third one to go is almost going into the back. And oftentimes there's enough evidence that actually suggests that if you have a posterior talofibular, that means that you've torn the first ligament, the second ligament, and a third ligament, you've actually sustained an ankle fracture. So you're ignoring the sprains and you're actually fixing the fracture. The reason I don't like defining a sprain as a stretching of a ligament is because the classification gets really convoluted. So I like to keep things simple. So from my standpoint, I just do grade 1, 2, and 3. 1 is the first one to go. A grade 2 ankle sprain is that the first and the second ligament have torn. And then a grade 3 is something that all of them have torn. The prognosis of even the worst ankle sprains is actually pretty good. Most people will actually do well. The reason that the data varies so much, anywhere from 35 36 to 85% of the worst ankle sprains won't do well because a huge majority of patients don't actually ever go and seek care for it. So they'll just try to walk it off, and then what ends up happening is that they fall into this pattern of just having recurrent ankle sprains. This is what I usually see in my practice, and I wrote this in a very workman's comp type of scenario, but a person or a worker, an employee, they twist their ankle, they roll their ankle, they're seen in the workman's comp clinic, they're given some sort of a brace, whether it's an air cast or an ACE wrap, and then they're immediately sent to physical therapy. And then if they don't have any improvement by 2 or 3 months, then they're kind of referred to us. Or the other thing that I see is that if it is a bad enough ankle sprain that the provider who's evaluating them is concerned about it, they immediately send them for an MRI. And then the MRI, says a gazillion things, and then at that point, they're sent to us. My usual protocol for conservative treatment is if it's a fresh, brand new ankle sprain and it's their first or their 10th, it really doesn't matter. They go into 2 weeks of protected weight bearing, and that does include wearing a cam boot. If they're symptomatic enough, they're black and blue everywhere, they're hurting, and it's very, very tender, then I will put them in a hard cast and make them non-weight bearing for about a week. After the boot and the protected immobilization, they go into a regular shoe and an ankle brace, and this is where physical therapy comes in super helpful. There's enough data out there that actually says that the lateral ankle ligaments are not there so much for stability like the other ligaments in the leg, but they're actually there for proprioception, meaning that when we're walking and we catch the curb, we don't just fall. We actually just catch it. It's an automatic conversation that happens. And so physical therapy, and I'm sure most of the therapists here would agree with this, is that they really emphasize on trying to get that ability to use the lateral ankle to kind of, stabilize themselves. I am of the opinion that an MRI is not necessary or required that early on. And I firmly believe that because, one, you can diagnose these 100% accurately. Two, if you get an MRI way too early, it will significantly overread because of all the trauma that just occurred. So in my practice, I like to wait at least 4 or 6 weeks to get it, unless it's something, out of the ordinary where I am suspicious for something else. From my standpoint, I get them. If you're in a walking boot and you don't have to wear steel-toe boots, you can go to work. You can do light duty. Moderate duty, it depends on what type of labor they're in. If it's something that they can wear a regular shoe and an ankle brace, they don't have to carry 2,000 pounds of steel every day, then they should be okay to go. And then regular duty, you should be able to get to regular duty 2 months after the initial appointment, not necessarily the initial injury. And then PPI, MMI, I usually pretty much have standardized this to where I do it at least 4 weeks after regular duty. So what happens generally in my practice, or what I've seen, is that the patient who does not go and seek care, or the patient who has done 3 months of physical therapy, or they're just not getting better, they really have 2 options. They can either wear a brace for the rest of their life, which most people despise the second I bring that up, or the second thing, to consider some sort of surgery. And this is where if it's been 2.5 months, they're really not getting better. My 2 criteria are they either have continued pain on the ankle, whether it's achiness or a dull ache or a pain, or general instability. And that can include whether they just keep rolling it again, or they just have an extreme lack of confidence with simple things like going down the stairs. We're not even talking, lateral movements or anything, going side to side. Surgery generally addresses four main things with patients who've developed chronic ankle instability, even from just one bad sprain. It addresses the ligaments themselves. It also addresses the impingement syndrome that often happens in the front of the ankle, where they have this feeling of they've got this seat belt in the front of their ankle just from the tightness and the inflammation. And a lot of that happens just from how the ankle kind of turns in so fast, so quickly that the joint itself collapses on each other. And then osteochondral defects, little fractures inside the ankle. And then the tendons that are on the outside that run through the ligaments, it addresses those as well, if there's ever an issue. Can you guys see this? It's a little washed out. So, picture one, I'm not a big fan of it because that's not exactly how I fix it, but the old school way, I consider myself pretty old school way, but what I think is a previous way of fixing lateral ankle instability, where you would have to be non-weight bearing for 6 weeks, you then finally can start walking. It's a very drawn out process, and what I have found is that a lot of sports injuries, if you fix them well with good rigid fixation, you should be able to get them back up pretty quickly. So I basically use it's basically a rope. There's nothing fancy about it. It's just sterile rope, and then you plug it into two of the bones. You basically recreate the ligament, and then it's like pants over vest. If you have pants that are too long, you just pull them up a little bit, and that's exactly what we have to do with the surgery, because the ligaments are a little too long and they're not giving you the support that you need. These arthroscopy photos just kind of highlight all of the stuff that happens inside the ankle that an MRI won't necessarily always pick up, and where a lot of the pain from lateral ankle instability comes. So oftentimes I'll get an MRI and it says three things: torn ligament, something completely random, and then the third thing is something that they've had for a long time. Does that mean that I only go in and I just fix their ligament? No, I think that's disingenuous, and I don't think you're fixing everything. And there's enough data out there that actually says that if you have a torn ligament, and they've done this over and over again, that doing an arthroscopy, guaranteed you'll find something. My surgical timeline for reconstructions of this type of injury is that after surgery, they can't walk on it. They have to be non-weight bearing for about 7 days. They see me in the office at 7 days. The splint comes off. They go into a walking boot and they can start walking. Right around 3 weeks after surgery, so they've gone home. They've walked in this boot for about 2 weeks or so. They come back. They get their stitches and staples taken out. They go into a regular shoe and an ankle brace, and I want them to go straight to physical therapy. If I have an athlete, I am setting up, or at least attempting to set up, their PT appointment right at the 3-week mark. And the reason is because you should be able to run, or at least do a light jog in a straight line by 6 weeks after surgery. The only reason I even make them non-weight bearing in a splint is just so that their skin can heal. It's not even the fixation or anything else. My general timeline for these work-related injuries, if they do require surgery, is they go back to light duty after 3 weeks. Right? You're in a regular shoe, you're in an ankle brace. You should be able to go and at least do a desk job or so on and so forth. Moderate duty, which for me is like 30, 40, 50 pounds. You should be able to carry that, push that, so on and so forth. Happens around 8 or 10 weeks after surgery. I think that's important because you don't want them to go back to work so early that they're miserable because of all the swelling that they may get. And then regular duty is designed to happen 4 months after surgery. And then PPI, MMI is usually around 20 weeks or 5 months after surgery. The biggest conclusions I would probably indicate is that even though, you read on Google and they're like, oh, you have an ankle sprain, keep it moving. In fact, in the professional sports, when they see a player that rolls their ankle, they actually don't let them sit, because the second they sit, they're going to swell up and they're going to start hurting. They actually have them keep playing, especially if it's an important game. And then what I found is that it is important to kind of immobilize them for the first 2 weeks or so. And then if they really don't have any improvement by 2 or 3 months, and you've tried everything, I may give them cortisone injections into the ankle and the subtalar joint below, just to kind of reduce some of the inflammation and pain. And if they're just not getting better, and we've got an MRI that says that this is super unstable, and I can reproduce the instability and pain, it just makes sense to offer them surgery. There's no reason to wait 6 months or a year if they haven't gotten better. And what we have to realize is that 55% of patients who don't go to their urgent care actually get better in like 2 weeks, and they go and they live their life. So if you haven't gotten better in 2 or 3 months with conservative treatment, you're not going to get better with just continuing conservative treatment. In my practice, and I do this pretty consistently, I never get an MRI right off the bat unless I'm suspecting an additional injury. I have found that it's just much more sensitive and it's much more specific, especially when we know that MRIs have like a 10% margin of error in the ankle and the foot. And then, this isn't the audience, but if I could tell, all of our wonderful emergency rooms and urgent cares that the rice and air cast is just not an effective method, and it really isn't. If it's, you can try it for a couple of days, but for weeks on end, it's just not going to work if you're still in pain. That's it. Questions?